How's study going?
Yeah, pretty good. How about you?
Yeah, it's not so then.
What's wrong? Are you okay? Acute ischemic stroke is the result of occlusion of blood flow to sections of the brain via infarction of an intracranial artery by an embolism or thrombosis. The morphology of the brain following stroke displays two distinct regions. The parenchyma is the neuronal and vascular tissue in the immediate area of infarction. The penumbra is the surrounding neuronal and vascular tissue which is supplied with blood from the collateral circulation of the brain but undergoes some ischemic damage. Functional deficits and clinical symptoms are determined by the extent and location of the ischemic parenchyma and penumbra affected. The brain's blood supply arises from the right and left internal carotid arteries and the right and left vertebral arteries. The internal carotid arteries each terminally divide into the right and left anterior and middle cerebral arteries, with the anterior cerebral arteries connected by an anastomosis, the anterior communicating artery. This forms the circulation to the frontal and parietal lobes and the superior surface of the temporal lobe.
The vertebral arteries form a confluence, which is the basilar artery at the pontomedullary junction on the anterior surface of the brainstem. From the basilar artery, the right and left posterior cerebral arteries collaterally branch to supply the inferior surface of the temporal lobe and the occipital lobe. The anterior, middle, and posterior cerebral arteries connected by the anterior communicating artery and the posterior communicating arteries form the circle of Willis inferior to the hypothalamus. This allows an alternate routes in case of vessel occlusion. However, only 18% of individuals possess a circle of Willis, with many variations arising in absent or fenestrated anterior or posterior communicating arteries.
Although MRI is more sensitive than CT in stroke diagnosis of all stages, including the subacute, acute, and chronic, CT is and remains the preferred modality as it is fast, inexpensive, and readily available in all hospitals. A CT scan can rule out lesions such as tumours or infections that could mimic a stroke and cytotoxic or intracellular edema of which MRI cannot detect at the acute phase. CT angiography through the use of an injected contrast are also used in hospitals on patients to exclude the site of arterial occlusion or stenosis for stroke causation. Due to its short time scan, high availability, and accurate pathological diagnosis, CT is the preferred modality to diagnose a patient suspected of ischemic stroke. Although MRI is more sensitive than CT in diagnosis, it risks the factor of delaying treatment and care to the suspected individual.
A hyperdense blood vessel is the first indication of ischemic stroke. Hyperdense refers to the high-density radiopaque signal caused by the occluded blood vessel. This is most frequently seen in the middle cerebral arteries 90 minutes after infarction. This CT image shows an occluded right middle cerebral artery, affecting blood flow to the lateral surface of the frontal, parietal, and temporal lobes. Compare this to a healthy patient, where no radiopaque artery will be seen. This image represents an axial CT scan 3 days after the stroke has occurred. This is when hypoattenuation and swelling is at its greatest, as seen here in the right frontal and parietal lobes. With progression, signs become increasingly easier to visualize, with loss in grey and white matter differentiation, and hypoattenuation caused by ischemic damage. When compared to a healthy patient, there are significant signal differences, with the healthy patient showing consistent semi-radiopaque regions.
A stroke may be mistakenly diagnosed as another neurological pathology or disorder, as the clinical presentations of stroke, including altered level of consciousness, hemiplegia, and difficulty communicating, are common to tumours, migraines, seizures, and postictal paralysis. These cases are referred to as stroke mimics and account for up to 30% of stroke hospital admissions. One of the most common stroke mimics is a brain tumour. To distinguish an ischemic stroke from a brain tumour, we can compare their appearance in these non-contrast axial CTs. In this CT, we can see a radiopaque lesion within the parenchyma of the left parietal lobe with surrounding edema. In contrast, this CT shows an acute ischemic stroke in the distribution of the right middle cerebral artery.
This is visualized as a region of increased hypodensity and loss of differentiation between the grey and white matter of the right cerebrum.